So the first topic that we are going to discuss in rheumatology is systemic lupus erythematosus. Systemic lupus erythematosus is a multi-system autoimmune disorder in which there's a formation of antibodies against the DNA and DNA that is present in a nucleus of every cell. So because there's formation of antibodies against DNA, so all the systems will be affected starting from head till toe. So everything will be affected. So what are the features of systemic lupus erythematosus? All the autoimmune conditions, they are more common in women. And systemic lupus erythematosus or SLE, it is also more common in women and people of Afro-Caribbean origin. Now we'll discuss some features of SLE. The general feature, they include fatigue, fever, lymphadenopathy, mouth ulcers, and remitting and relapsing illness. There will be multiple painful mouth ulcers present in SLE. So after general features, we will discuss skin manifestations of SLE, and skin manifestation, they include malar or butterfly rash and discoid rash. Malar or butterfly rash, it spares the nasolabial folds. So this is a type of rash in which nasolabial folds are spared. And discoid rash is a scaly erythematous well demarcated rash in sun exposed areas. Raynaud's phenomena may also be present. So these are the skin manifestation of SLE. Important skin manifestation is malar rash, discoid rash, and photosensitivity. And also Raynaud's phenomena may also be present in 1/5 of the patients, but it is usually mild. Now, musculoskeletal manifestations. Musculoskeletal manifestation, they include arthralgia and peripheral and symmetrical polyarthritis. Symmetrical polyarthritis, many joints will be affected and it will be symmetrical. Joints on both sides will be affected. Cardiovascular manifestation. So now we can start from the head, and that is in the brain, it can cause cerebritis, which will result in anxiety, depression, psychosis, and seizures. And also there is hair loss as well. After head, there is chest cavity, and chest cavity contains two important organs that are heart and lungs. So cardiovascular manifestation of SLE, it includes, remember that all the body cavities such as pericardial cavity, pleural cavity, peritoneal cavity, they are all affected in SLE. So in heart, it can cause pericarditis. It is the most common cardiac manifestation, myocarditis, and even endocarditis. So all the three layers of the heart can be affected. In respiratory system, it can cause fibrosing alveolitis and pleurisy or pleural effusion. Now in the abdomen, it can affect kidneys, which will result in a condition or kidney failure or kidney damage and proteinuria. The type of glomerulonephritis that is present in SLE is diffuse proliferative glomerulonephritis, is usually present in the renal. When there is a renal involvement, we call it as lupus nephritis. And we have already discussed neuropsychiatric symptoms such as anxiety, depression, psychosis, and seizures can also occur in patients with SLE. So you have seen that SLE can affect any organ of the body. It is a multi-system disorder. So the skin manifestation, a musculoskeletal manifestation, cardiac, respiratory, renal, and neuropsychiatric manifestation. You can remember this like this systemically. So the initial investigation in case of SLE is ANA, anti-nuclear antibody. It is more sensitive. Confirmatory or most appropriate investigation is anti-dsDNA. ESR, complement C3 and C4 level can also be done uh, in helping to make a diagnosis. And if there is renal involvement, there can be proteinuria and hematuria because of diffuse proliferative glomerulonephritis due to involvement of joints. There can be painful joints and morning stiffness can also be seen. So this was all about features of systemic lupus erythematosus and its diagnosis. So the initial investigation is ANA and the confirmatory investigation is anti-dsDNA. Other investigation they can include raised ESR, normocytic normochromic anemia, and low C3 and C4 levels. Monitoring of the disease can be done through ESR. So ESR is if they ask you in the question that which test can be used for the monitoring of the disease, that is ESR. Remember that anti-dsDNA titers can be used for disease monitoring as well, but anti-dsDNA is not present in all the patients. So that's why ESR may be a better option for the monitoring of the disease. And CRP levels, they are usually normal in SLE, and if they are raised, then it may indicate an underlying infection. So the initial investigation or the most sensitive investigation is ANA, and most specific or definitive investigation is anti-dsDNA. An investigation to use in the monitoring of the disease is ESR and anti-dsDNA. Management of SLE, it include if there are skin lesions such as malar rash or discoid rash or photosensitivity, arthralgia or joint pain, and myalgia and oral ulcers. If they are present, then hydroxychloroquine or HCQ will be used, and NSAIDs can also be used along with hydroxychloroquine for pain management. In more severe cases, prednisolone or steroids will be used. And if there is involvement of the lungs, such as if the patient has lupus nephritis or any vasculitis, then cyclophosphamide will be used in the management of SLE. So this was all about SLE, its diagnosis and management. Is it clear? Is there any question? Okay, now some drugs can cause SLE-like symptoms as well. And when this happens, the drugs such as hydralazine, chlorpromazine, and isoniazid. Sometimes when we take any of these drugs, the patient may develop an SLE-like symptoms. This is known as drug-induced lupus. Remember that drug-induced lupus is also an autoimmune phenomena. Drug-induced lupus, they are less severe and usually reversible. When the drug that is causing these symptoms, it is discontinued, the symptoms usually reverse after stopping the medication. So drug-induced lupus is lupus that is caused by drugs, or if someone develop features of SLE after taking a drug such as hydralazine, chlorpromazine, and isoniazid, then it will be drug-induced lupus. And stopping the medication is the only option because it is reversible. The symptoms usually resolve within months after stopping the medication. And the other difference between drug-induced lupus and SLE is that the symptoms in drug-induced lupus, they are mild, and major organs are not usually affected, such as heart, lungs, and kidney. They are not affected in drug-induced lupus. Only there is skin manifestations or oral ulceration. So this is a diagram which is showing SLE involvement of different organs in SLE, starting from the CNS, then heart, then lungs, then kidneys, then fingers and toes, joints, etc. So a woman with pain and stiffness of joints of her hand has a rash that crosses her nose and cheeks. Medical history significant for mouth ulcers. What is the investigation of choice? So a female with joint stiffness or arthritis, she has a rash that crosses her nose and cheeks, a butterfly rash, and medical history is also significant for mouth ulcer. So what is the investigation of choice in this case?
So it's A ANA, but the definitive is anti-DSD.
So if they ask about the initial investigation, then it will be ANA. Or if they ask about the most sensitive investigation, again it will be ANA. And the investigation of choice or most appropriate investigation will be anti-dsDNA in
DNA.
case of SLE.
So these medication, hydralazine and chlorpromazine, what are they indicated for? I mean, isoniazid.
Adrenaline is an antihypertensive medication. Isoniazid is used in the management of tuberculosis,
Yeah.
and chlorpromazine is a zine family. It is used in vomiting, in the treatment of or in the management of vomiting.
Yes. Okay. Thank you.
Remember that the Meller
It
rash
has
of
to be.
SLE.
Sorry.
What?
Sorry. It has to be used for a prolonged time. These medications, and then they can someone can get this drug-induced lupus, or it can happen like
Yes,
in a.
usually a chronic use result in the uh, drug-induced lupus, but a one-time use can also result in drug-induced lupus.
Oh, okay. Thank you.
So the Meller rash of SLE, it spares the nasolabial folds, while the rash of dermatomyositis, it is a condition that we will discuss in the coming slides. It does not spare the nasolabial folds. So remember this point. And discoid lupus, it is called discoid lupus erythmatosis because cone-shaped lesions are produced on the areas that are exposed to sunlight. Now, a second topic or second autoimmune condition that we are going to discuss is rheumatoid arthritis. Rheumatoid arthritis, we saw in SLE that SLE causes arthritis that is symmetrical and that is polyarthritis, that it involves many joints. So SLE can present with bilateral and symmetrical polyarthritis as well. Similarly, rheumatoid arthritis can present with the features of these joint involvement as well. But in rheumatoid arthritis, the involvement of joint is more common, while in SLE, other features can also be present. So what is the presentation of rheumatoid arthritis? Bilateral and symmetrical polyarthritis, joint stiffness in the morning that improves with activity or settle down with activity. Involvement of proximal interphalangeal joint, metacarpophalangeal joint, wrist, knee, and cervical spine joint. So rheumatoid arthritis, it usually involve proximal interphalangeal joint and metacarpophalangeal joint. So the first joint, the first interphalangeal joint is basically proximal interphalangeal joint, then metacarpophalangeal joint, then wrist joint, knee and cervical spine joint can also be involved in rheumatoid arthritis. But small joints such as interphalangeal and metacarpophalangeal joints, they are more commonly involved. Swan neck and button ear deformity and rheumatoid nodules may also be present in rheumatoid arthritis. Swan neck deformity, let me show you the diagram. You can see this flexion of an interphalangeal joint. This is known as swan neck deformity. So swan neck deformity is basically a flexion of the base of the finger and extension of the middle joint. You do not need to remember this detail of swan neck deformity. You can just simply remember that there is swan neck and buttonose deformity present in rheumatoid arthritis. So someone with a swollen, painful joints in hands and feet, and the stiffness is worse in the morning and it improves in the evening or with activity. And a positive squeeze test. What is a positive squeeze test? Squeezing across the metacarpal or metatarsal joints. If there's a discomfort on squeezing across these joints, then we'll say that squeeze test is positive. So positive squeeze test and joint stiffness or swelling that is worse in the morning and gets better in the evening, you will suspect rheumatoid arthritis. Initial investigation is RA factor and ESR and CRP. ESR and CRP, they will be raised and RA factor will be positive. And the more specific or definitive investigation or investigation of choice is anti-CCP, anti-cyclic citrullinated peptides or anti-CCP. So initial investigation include ESR and RF factor, and the definitive or more specific investigation is anti-CCP. In acute conditions or to manage the flare of rheumatoid arthritis, painkillers such as NSAIDs and corticosteroids they are given. While for long-term management, disease-modifying anti-rheumatic drugs such as methotrexate and sulfasalazine, and they are used. The use of methotrexate and sulfasalazine, because they inhibit the autoimmune system or the inflammation or the overactive immune system or the excessive inflammation that is going on in rheumatoid arthritis. So they slow down the disease progression and prevent deformities. So this was all about rheumatoid arthritis. Rheumatoid arthritis, if it is not treated, it can lead to joint deformities.